Good morning. Now we are on to the second leg of our report, and today we'll be discussing about physician-assisted dying. By definition, physician-assisted dying is a suicide by a patient facilitated by means such as a drug prescription or by information such as an indication of a lethal dosage provided by a physician who is aware of the patient's intent to die. One of the major figures of this topic is Dr. Jackie Vorkin, who is also known as Dr. Death. Dr. Jackie Vorkin is an American pathologist who developed the physician-assisted suicide or PAS machine. He proposed giving murderers condemned to die the option of being executed with anesthesia rather than by gas or by electric chair in order to harvest their body organs for medical experimentation. In 1990, Janet Adkins became the first patient to avail of the PAS. She was an Alzheimer's disease patient. This led on to Dr. Kevorkian to be charged with murder, which were later dropped as there were at that time no laws in Michigan regarding assisted suicide. In 1991, Dr. Jackie Kevorkian's license to practice medicine was suspended with permanent injunction banning him from using his PAS machine. However, this did not stop Dr. Jackie Kevorkian to practice PAS. In 1993, a statute outlawing assisted suicide was developed, and the following year, in 1984, the Michigan Supreme Court ruled PAS as a common felony. This led on to Dr. Kevorkian to be jailed twice. However, his lawyer, Geoffrey Fieger, escaped conviction by arguing that the administration of medicine with the intent of relieving pain and suffering is not guilty of any criminal liabilities. Between May 1994 and June 1997, Dr. Jackie Kevorkian stood trial and was persecuted 4 times in the deaths of 6 patients. 3 of the trials ended in acquittals, and the 4th was declared a mistrial. In 1998, Dr. Jackie Kevorkian made headlines by videotaping himself injecting Thomas Hughes, who was suffering from ALS or the Lou Gehrig's disease, with a little drug that caused Mr. Hughes' death. Dr. Kevorkian later sent the tape to CBS, which aired it on national TV. And on March 1999, he was found guilty of second-degree murder and illegal delivery of controlled substance. 8 years later, in June 2007, he was released from prison after he promised not to conduct another assisted suicide, and he died at 83 years of age due to pulmonary thrombosis in 2011. For many years, the effort to change government policies regarding euthanasia of humans in the 20th and 21st centuries have met limited success in the Western countries. One of these countries, by example, is the Netherlands, who was used to be known as Holland. The Netherlands became the first European country to decriminalize euthanasia and assisted suicide by a law passed in 2001. Euthanasia is defined in a broad sense as encompassing all decisions of doctors and others intended to hasten or to bring about the death of a person by act or omission in order to prevent or to limit the suffering of that person, whether or not it is his or her request. However, in the Netherlands, this definition is limited, and it only refers to the deliberate termination of the life of a person on his request by another person, which falls under active or voluntary euthanasia. According to the Dutch Penal Code, euthanasia is a crime. However, it is not qualified as murder and is dealt with in a separate section. According to Article 293, anyone who takes another person's life at his explicit and earnest request will be punished by imprisonment to a maximum of 12 years. In a court case in 1973, a general practitioner was prosecuted for ending the life of her mother, who had suffered a cerebral hemorrhage, was partly paralyzed, was deaf, and had trouble speaking. After the mother had repeatedly expressed the wish to die, the daughter ended her mother's life by giving her a little dose of morphine. The court of Leeuwarden found her guilty not because she had hastened the death of her mother, but because she had directly ended her life instead of stepping up the doses of morphine, with a secondary effect that would have only shortened the patient's life. So the argument here is directly ending her life versus only shortening the patient's life. In Almar's case, a 95-year-old woman who was seriously ill with no chance of recovery, the weekend before her death, she suffered substantial deterioration and was unable to eat or drink and lost consciousness. She had pleaded with the doctor several times to put an end to her agony. After regaining consciousness, she declared that she did not want to go through such an experience again and urged her physician to end her life. Finally, the doctor decided to act according to her wishes, as he was convinced that every single day would only be a heavy burden to the patient. In Supreme Court in 1984, doctors prosecuted for euthanasia have defended themselves in different ways. The only plea for acquittal which was not dismissed is the invocation of a situation of force majeure or necessity resulting from a conflict of duties, which are the duty towards the patient to alleviate hopeless suffering and the duty towards the law to preserve the patient's life. A doctor will not be convicted if he or she has carefully balanced the conflicting duties and made a decision that can objectively be justified. Under the Royal Dutch Medical Association, they had formulated a set of criteria in which euthanasia could be permissible, and these are: the request for euthanasia must come from the patient and be entirely free and voluntary, well considered and persistent. The patient must experience intolerable suffering, physical or mental, with no prospect of improvement and with no acceptable solutions to alleviate the patient's situation. Euthanasia must be performed by a physician after a consultation with an independent colleague who has experience in this field. There are several factors why patients would want to think of euthanasia, and the more common ones are loss of dignity at 57%, followed by pain at 46%, then being dependent and tiredness of life. Some of the controversies surrounding euthanasia is that in about 1,000 cases, doctors prescribed or administered a drug with the objective of shortening the life of a patient without the latter's explicit request. In most cases, the patients were in the end stage of malignant disease, dying, and were suffering grievously. Most patients were incompetent, but in more than half of the cases, they were still competent at the time of the decision. These cases do not meet strict criteria for euthanasia developed in jurisprudence. The prevalence of euthanasia, it occurs more often in general practice in hospitals, and it is performed as much as 3 times more often by general practitioners, as explained by the general long-standing doctor-patient relationship. Under the Dutch law, a physician can only issue a death certificate in the case of natural death, and under the new procedure in 1990, the physician must inform the local medical examiner by means of an extensive questionnaire. Then the medical examiner then reports to the district attorney, and the public prosecutor will issue a certificate of no objection to burial or cremation, or he may order an investigation and decide to prosecute the case. Under the revision of the Penal Code, Article 293, the government made it clear that a doctor performing euthanasia would never be completely immune from criminal prosecution. On the whole, the position taken by the government would seem ambiguous, because euthanasia will remain a crime even if it is carried out by a doctor who complies with all the restrictions elaborated in the court rulings. At the same time, the modification of the Burial Act implies that a doctor will not be prosecuted if he or she carefully commits that crime. Now moving on to the Oregon's legalization. In the late 1980s and early 1990s, Senator Frank Roberts, who was suffering from cancer, introduced 3 physician-assisted dying bills. However, none of these bills got out of committee, but they became templates for later bills. And in 1993, the Oregon Right to Die Committee was formed. And in Oregon's Measure 16, it expressly prohibits euthanasia by lethal injection. In 1994, Death with Dignity law was passed, which states that the person who sought physician-assisted suicide would have to meet certain criteria. This person must be terminally ill, he must have 6 months or less to live, makes 2 oral requests and 1 written request for assistance in dying, convince the physician that he or she is sincere and is not acting on a whim, and that the decision is voluntary. This person must not have influenced by depression. This person must be informed of the feasible alternatives, including but not limited to comfort care, hospice care, and pain control. And this person must wait for 15 days. If this person meets all requirements, he or she could receive a prescription of a barbiturate that would be sufficient to cause death, and physicians would be prohibited from inducing death by injection or carbon monoxide. And in 1984, Oregon became the first U.S. state with a physician-assisted dying statute. And again, to note that the Measure 16, which prohibits euthanasia by lethal injection, is regarded as one of the most controversial ballot measures in Oregon's history. Thomas Constantine, the administrator of the Federal Drug Enforcement Administration, or the DEA, wrote a policy statement which said that prescribing drugs to help terminally ill patients kill themselves would be a violation of the Controlled Substances Act. Attorney General Janet Reno agrees to review the matter. However, in 1998, she reversed Constantine's ruling stating that doctors who use the law to prescribe lethal drugs to terminally ill patients will not be prosecuted, and that drug laws were intended to block illegal trafficking in drugs and not to cover situations like the Oregon Suicide Law. She further argued that the Oregon Death with Dignity Act as written is well beyond the regulatory purview of the CSA. And in March 1998, a woman in her mid-80s died from a lethal dose of barbiturates, which had been prescribed by her doctor under the Oregon law. She became the first person to publicly use the law to commit suicide, and she had been fighting breast cancer for 20 years and recently been told by her doctor that she had less than 2 months to live and had been experiencing increased difficulty breathing. To quote U.S. Senator Ron Wyden, Oregon's Death with Dignity Act has helped to improve end-of-life health care for thousands of Oregonians. We are proud Oregon leads the way in palliative care, hospice care, and in providing peace of mind for the terminally ill. Now let's talk about the types of euthanasia. You have passive, active, voluntary, involuntary, assisted, and indirect. Voluntary euthanasia is performed at the request of the patient, while involuntary, also known as mercy killing, is taking the life of a patient against his will. So it is not requested by the patient. Patients are competent and make no request to die. In non-voluntary, the patient is not competent to give consent, such as a comatose patient. Now let's differentiate active versus passive euthanasia. Active euthanasia is taking specific steps to cause the patient's death, such as injecting lethal dose of a drug, while passive euthanasia is the lack of action rather than taking any action. So there is no action at all. It is ceasing or not starting medical treatment that keeps a person alive, such as respirator and feeding tube. So basically, it is killing a person versus watching that person die. So these are just some of the analogies of your active and passive under voluntary, involuntary, and non-voluntary euthanasia. Moving on, killing versus letting die. To kill someone, this distinction is the basis for differentiating the two forms of euthanasia, which are your active and passive. To kill someone, which falls under active euthanasia, is to take a definite action to end his or her life, such as administering a lethal injection, while to allow someone to die, which is passive euthanasia, is to take no steps to prolong that person's life when those steps seem called for, such as failing to give a needed injection to live. So some of the advocates of euthanasia argued that there is no moral difference between killing a patient and letting him die, because the moral parity of killing and letting die can be understood to have two aspects. Does it concern a moral good, or does it concern a moral evil? So they argued that you are as guilty of a wrongdoing if you let someone die as much as killing that person. So here, killing and letting die is equally morally evil. On the other hand, if letting someone die or passive euthanasia is considered as morally good because it ends the suffering of your patient, then why is killing someone to end suffering or active euthanasia also not a moral good? Aren't these equally morally good? Further argument by Pellegrino. For Pellegrino, the difference is that in active euthanasia, the doctor is the direct cause of the patient's death, whereas in letting the patient die or passive euthanasia, it is the illness that killed the patient. Therefore, they are not morally equivalent, because in the first case, the doctor does something, and in the second case, he did nothing. And according to James Rachel, this is not true, because in passive euthanasia, the doctor does nothing to the fact that he allows the patient to die. And letting someone die can be subject to moral evaluation, good or bad. Passive euthanasia, therefore, is seen as a medically acceptable because death is seen as an equal or lesser evil than suffering. So if passive euthanasia is acceptable to eliminate the equal or greater evil of suffering, then so is active euthanasia. Terminating the life of a seriously ill person is not morally distinct from letting them die. So, relief of suffering. One of the reasons given for the interest in physician-assisted suicide, but studies suggest that patients in pain want pain relief and not death. That's according to Culber 1996. However, not all patients are the same, right? So who decides when the patient is in pain? Many healthcare providers refuse to accept the patient's own statements, and that one should wait for objective expressions of pain because pain medication is too attractive to the patient. Generally, when the patient says he is in pain, his judgment should be the one that matters. Also, dependence upon pain relief is due to the persistence of pain and not to addiction. Hospice. Hospice remains an underutilized form of care for the dying patient. The average length of stay is short, suggesting physicians or patients and their families are reluctant to accept a determination that the patient is terminal. This suggests that many patients continue to receive aggressive medical care beyond the end of a reasonable hope of improvement, which can harm the patient and may in fact shorten the patient's life. So the right to die is considered as one of the triumphs of autonomy. So now let's talk about patient autonomy. Autonomy in medical ethics is to see the patient as a lone individual capable of making decisions about the general course of his or her life, which requires the ability to discern, understand, and decide among options without coercion or the undue influence of others, either in accordance with moral law or with the individual's discerned preferences and values. Any individual who is allowed to make decisions related to their health care must have capacity because an autonomous choice does require a careful and thoughtful evaluation. So capacity, by definition, is the patient's ability to make healthcare decisions. And if we talk about capacity, it is also important to talk about competence. And competence is usually reserved for legal proceedings. It is the obligation of the treating physician to determine if an individual has the ability to fully understand his or her medical condition, the treatment options presented, and its implications. Further, all physicians are permitted to make determinations of capacity, and a psychiatric evaluation is not required. A psychiatric consultation may be warranted if the treating physician is unsure of the individual's ability to make decisions or if it is believed that there is a psychiatric comorbidity. Now, who knows what is best for the patient? Physicians believe that they are the best qualified to assess risk for the patient. However, many patients want the right to make their own judgments about what is acceptable risk. In order to make the best decisions about acceptable risk, patients as well as their families need to be informed. Moreover, the physician was assumed to know what is best for the patient and would dictate what actions were necessary to treat the patient. Although this may raise one's concerns about a patient's capacity, it is not a valid assumption because, by conclusion, the moral and legal right of a person to accept or decline a recommended medical intervention reflects the core philosophy of autonomy that only an individual can truly know what is best for him or her. The American Medical Association, or the AMA, fully embraces and supports patient autonomy. It is not, however, ethically incumbent upon physicians to be part to all of the decisions as the patient may make for themselves. Further, the AMA has policy affirming the highest quality care at the end of life, especially quality hospice and palliative care, without intentionally delaying or hastening death, can alleviate nearly all physical suffering and much existential suffering at the end of life. Patient autonomy is important, but never the only factor in a decision and is never used to determine overarching professional ethics. So if you can still remember the roles of the physician, these are reminders. As a physician, you must take the initiative in discussing termination of care for the patient. Inform the patient clearly and completely about his condition, which includes explaining in simple terms which are within the understanding of the patient, because failure to do so is tantamount to not obtaining informed consent for the said treatment. At times, to tell the patient when it is likely that the patient will die no matter what is done, and to provide treatment that does not harm the patient. So what would you do if a patient asked you for PAD? Pretending that it's actually allowed in the Philippines. It is important to be respectful and caring when the patient is asking for a request for PAD. When you come across with a patient who is willing to die, who is asking to die, one can only imagine his situation, to actually ask for death as a better option than anything else, more than living, more than anything. So one can only assume that this patient, believes that there's nothing that can be done in his or her situation. But as a doctor, you must always remember that there is never nothing that you can do. There is always something that you can do. If you cannot treat, you palliate. If you cannot palliate, give comfort. Always show your respect, always offer your care. Moving on, virtually every request represents a profound event for the patient who may have agonized over his situation. The patient's request should be explored to better understand its origin and to determine if there are other interventions that may help ameliorate the situation. Palliative care physicians recommend the following process for evaluating and responding to request. To wait directly to respond to the request until you have explored the reasons for the patient's request, and to discuss various ways of addressing the patient's pain, suffering, hopes, and fears, to evaluate for depression or other psychiatric conditions, to assess the patient's decision-making competence, to engage in discussion such as diagnosis, prognosis, and goals for care. Make sure to assess patient understanding, to evaluate patient's physical, mental, social, and spiritual suffering, taking into account the patient's support system as well as personal and professional pressures and stressors, to discuss all alternative options like palliative care and hospice, and to consult with professional colleagues regarding the patient's situation, and to assist the patient to complete advanced directives like to not resuscitate orders and provider orders for life-sustaining treatments, and appropriate ensure preferences are followed. So what if the request for PAD request persists? Each individual clinician must decide his or her own position and choose a course of action that is ethically justifiable and legally permissible. It is useful to carefully reflect on where you stand and to be prepared to openly discuss your position with the patient, acknowledging and respecting difference of opinion when it occurs. And it is very important to remember to be clear and transparent about your position. Under no circumstance does a physician should feel forced to provide assistance if he or she is morally opposed to PAD. So these are the mistakes and abuses that surround the euthanasia. It has lots of potential for abuse, especially for the vulnerable population who lack access to quality care and support, which tend to lean towards assisted death. Also, it is a huge challenge to catch all instances of coercion or exploitation, and there's this danger in dying too soon and losing valuable months or years, such as what happened in Dr. Richard Radke, who was diagnosed with a very disabling form of muscular sclerosis, and the doctors classified him as terminally ill. He experienced severe depression for 2 years and would have opted for assisted death if it was available at that time. Fortunately for him, it wasn't, so he had to keep on living. And he lived on for long years as well-known retired academic oceanographer, a president of a charitable foundation, and was happily married and a father for many years. These are the fallibility of the profession. There are risks of errors which are almost always present, and there is uncertainty in diagnosis and prognosis. Hence, not all terminal illnesses are correct. The affected group could include people who may be mistakenly diagnosed as terminal but who may have many meaningful years of life ahead of them. The state has the obligation to protect the lives from these inevitable mistakes and improve the pain and symptom control at the end of life, especially for the vulnerable population. So that's it, and thank you for listening.